This is question 2A. I have been studying some chiropractic neurology recently. The opinion of the instructor is to do the neurological treatments first. I understand that you recommend doing the QA protocol first and then performing the neurological assessment. Am I correct? This question is inserted here because it more than adequately is answered by the above 3 case histories and many other similar IRT stories. The answer is yes, do the protocol first, at least through step 9, at least through steps 4, 5, 6, and 9, where you get to switching. Because following the the correction of IRT and switching, many neurological findings will either disappear or change significantly, even to the opposite side from the original presentation. I mean, I've seen patients who had pupillary reflexes, which is one of the big tools we use in chiropractic neurology, being asymmetrical, and the side of asymmetry shifting after fixing injuries. Come on. So if you don't do your AK and your QA assessment, at least through step 9, at least QA steps 4, 5, 6, and then maybe skip to 9 for the switching, you're likely to get all different types of neurological feedback that will just be confusing and make more complicated in the patient. You could do a Romberg test, a 1-foot Romberg test, and do IRT, and all of a sudden the problem switches to the opposite 1-foot Romberg test. I mean, these things happen all the time. So when we put together the QA protocol, I'm a chiropractic neurologist. We synthesize chiropractic neurology with AK, with biochemistry of nutrition, and so on. And what I learned to do was to do the things in the order that I presented them in the QA protocol that we presented them today, relative to switching and relative to injuries. Because when you do them that way, it puts all the apples on one side, all the oranges on the other, and you can get a more clear neurological picture. Now, sometimes you do all these things and the neurological findings don't change, but often enough they do that you should do a basic neurological assessment on the patient, but before doing in-depth neurological assessment, clear steps 4, IRT, and even set point or NSB. Clear steps 5 and 6, which create small intestine switching, and clear step 9, which includes the hyoid and the K27 switching that Carrie talked about us today. Clear these things, and following correction of IRT and switching, many neurological findings will disappear or change significantly, even to the opposite side from the original presentation. So I would totally disagree with the fact that you should do all the neurological assessment first, because you're going to be painting over a lot of rust. You're going to be finding a lot of things that are secondary findings. Not that they're not important, but the fact that we put this protocol together based on the understanding of neurological findings and the neurological exam and what to do first, next, and last. The neurology is extraordinarily important, and I do it every day in my office, but I do it in the protocol format that we talk about. We slightly alter that when there's a problem in the brain on fire. We slightly alter the protocol, but it's virtually the same QA protocol that we use before we add the other neurological techniques down the road a little bit. Jim Hoag's idea of using IRT laser injury on those 3 cases to the brain points that out more clearly than anything, but any IRT, any set point technique, any switching pattern can disrupt the normal neurological findings. And this is something chiropractic neurologists just don't know about. So when they say, oh, you should do the neurology first, it's an opinion because they don't know AK and they don't know QA. There's not a chiropractic neurologist out there who is an instructor who knows anything about QA or AK. They think they do, but they don't. I'm not being critical of them because they know the neurology a lot better than I do. But I'm telling you, they haven't studied QA. If they studied QA and looked at the things the way we look at them and the way I've looked at them for 40 years now, and since I started taking chiropractic neurology in 1989, it's a long time, looking at the 2 things together, you get a different opinion than if you just look at one focus of that and look only at the neurology part and make assumptions based on what you think should be the case because of what you do. Well, I've had to reorganize what I did, started in 1989 with chiropractic neurology and putting that and synthesizing that with AK, and that's what the QA protocol is. So do the QA protocol, add the chiropractic neurology to that. The patients will be much more optimally served, and putting the 2 things together will get you through many difficult, otherwise chiropractic neurology presentations. There are built-in safety valves in the QA protocol, especially when you add beyond IRT to that original QA protocol, to protect against doing any damage with any techniques that you might otherwise consider could happen in neurological imbalances of areas of transneural degeneration and so on. They're built-in safety valves in the chiropractic neurology concepts built into the QA protocol. And if you read the paper on the basic comprehensive view of what applying applied kinesiology techniques is, the basis for the QA protocol, you'll see those are discussed in there. So remember that injuries and muscle imbalances will create changes in the cerebellum on the same side, the opposite mesencephalon on the opposite cortex, which can sometimes be presented as neurological findings, which can just go away when you fix the QA protocol steps we've been discussing, steps 4, 5, 6, and 9.